A common question that would arise is, should we save some of these great drugs for down the line? So I explained this with the analogy of, do we use a strategy like we use in soccer, or do we play like you play in baseball? So in soccer, you put your best players since the first game. If you're playing Messi, you don't put him in the bench hoping that your team will get to the World Cup finals. In fact, he's going to be playing since game number 1. Whereas in baseball, you can save some great players for those late innings. And as we have gone through the process of clinical research in myeloma, more and more we think for the frontline diagnosis, and perhaps even for the first relapse, it has to be like soccer. And I know this is different for different diseases. Sometimes I will hear people say, well, for instance, in breast cancer, we do sequencing and we save some of these drugs for down the line. The reality is that in multiple myeloma, putting your best foot forward pays off. Now, one must recognize, and this is very, very important, if you have a patient who gets optimal therapy, it does not necessarily assure that they're going to get to the next line of therapy. Likewise, if someone gets suboptimal therapy, they're not necessarily going to get to that second line of therapy. So there's an attrition process. So the more the reason to try to keep those patients under optimal control until the time comes that they might need second line therapy. Now, baseball may be fine for further down the line, maybe for third and fourth line. And in fact, this analogy was given to me by a patient of mine who was an avid baseball fan. And he said, for me at this stage, it's not about winning, it's just about not losing. So with every new line of treatment you give me, I actually have a new option. So I have another inning.
There's a need for treatment planning throughout the entire disease course. It is entirely clear that you want a doctor who designs a therapeutic strategy for the duration of your disease and your life, and not just a strategy for getting you to a remission. And so that's very important. And part of the way you implement that strategy is to monitor the response to the drugs that you're using. So if you see a good response, you're making progress. And so aiming to get first to a PR, then to a complete response, then an MRD negative complete response, I believe is becoming the kind of the first part of the strategy for myeloma. The more people you get to deep responses, the better the long-term outcomes. It's very important, I believe, to use the most effective combinations up front. That's the time when the disease is at its most sensitive and you can get the best long-term outcomes for patients. So I would very much design a triplet or quadruplet for upfront patients. You should think of different stages when you treat. It's not analogous to some of the solid tumors. So there's an induction phase where you maximize your response. For younger patients who can tolerate it, you should consider stem cell transplant. Then after the stem cell transplant, there's a consolidation phase where you can deepen response even further. And then long-term, and where there's good data now, maintenance seems to be able to control the disease for a prolonged period of time.
In myeloma, the upfront and subsequent therapies are really, I like to say, a planned pathway, really from when the patient first comes in at diagnosis. I try to use the medications that are the most potent right up front. And I think that strategy is most important for the transplant-eligible patient population where potentially we might have the ability to cure some of those patients. And then for the elderly frail to really try to make their medications as less toxic and as effective as possible. So when I start somebody on an initial therapy, say I start them on RVD or RVD light, I'm already thinking about what's going to be the next therapy and the next therapy. And the second line therapy for me is often a carfilzomib-based regimen or potentially a monoclonal antibody-based regimen. We have 2 new antibodies, daratumumab, elotuzumab. And we often think about, okay, that's second regimen. What's our third regimen going to be? And in myeloma, we do a lot of, we call this ping pong approach, where we give maybe an IMiD backbone first and then a PI backbone next, and then go back to a second generation IMiD and maybe then a second generation PI. So we're already thinking multiple regimens ahead when we're really defining a treatment path for an individual patient.